maybe it's a losing role since the very beginning. Also because, you know, it cannot be against the use of invasive ventilation and the ventilatory protective strategies in RDS. So I try to play my role and giving you some different points of view. Let's imagine that we do have a 55-year-old man with no history of cardiac failure or COPD that has a worsening dyspnea in the last 2 days. Fever, sore throat for a week, and no productive cough. PaO2, VO2 110 when breathing almost 100% of oxygen. PaCO2 28, APH 7.48, and normal lactate. Tachypneic, and blood pressure 114/70 with a heart rate which is relatively high. This can be, for instance, the situation radiologically speaking. At this point, one may ask, what should I do? Giving oxygen in a different way, non-invasive ventilation, the high-flow oxygen therapy, delivering the non-invasive ventilation through a different device, such an helmet, or intubate the patient. The real matter is that whilst we do have a relatively easy approach when you look at patients whose PaO2, VO2 is something in between 300 and 200, at least looking at the new definition, we do have a room for the application of spontaneous breathing forms, namely the non-invasive ventilation. This story is totally different for what concerns the other patients whose severity is much higher, and PaO2 or VO2 is below 200, and where at times there are some attempts of keeping the spontaneous breathing, but most of the inconveniences has been shown by Laurent just in his presentations. On the other hand, we know that there are physiological effects of non-invasive ventilation, at least in the milder forms, those that were defined as acute lung injury in the past, and where there is a substantial reduction of the workload of the respiratory muscle and the respiratory work of breathing. And however, we know quite well, looking also to many different epidemiological studies conducted in France and in other situations, where we have a failure of non-invasive ventilation in the context of acute de novo hypoxemic respiratory failure, there is a substantial increase of that. So again, something that is against. The mechanism of ELI, we know that is largely related to the transpulmonary pressure. And as soon as we apply the pressure, maybe in patients not spontaneously breathing, something like transpulmonary pressure of 25 centimeters of water, but as soon as the spontaneously breathing starts, you may have a much higher transpulmonary pressure, which is related to the spontaneous effort that has been done by the patient. However, one of the things that is never analyzed deeply is how can be the amount of reduction of the inspiratory effort on part of the patient as soon as you have indeed the possibility of measuring the transpulmonary pressure. But the real problem is that during spontaneous breathing and in patients who are not intubated, getting all the different data coming from physiological measurements is extremely difficult, because indeed, when the inspiratory transpulmonary pressure is almost impossible to determine during non-invasive ventilation. However, can be surrogated by the dynamic transpulmonary pressure, whose measurement requires another limitation, the esophageal balloon, and not always is feasible in all the patients. So there is a limitation to know some of the information. What could we do? Maybe also looking at the driving pressure could be a solution. Our problem is over distension, and we know quite well that as soon as we have a level of driving pressure which is above a specific threshold, which is something like 15 centimeters of water, we may be almost sure that this corresponds to an overdistension, especially of the healthy baby lung. And know also that there is some detrimental effect of spontaneous breathing on the transvascular pressure, with a migration of a certain amount of fluid and floating on the alveoli. But also in this context, the study that's been done by the group of Goranet and Stierna in the 80s demonstrated that under spontaneous breathing, the lymph flow and then the drainage of the amount of fluid into the interstitial space is indeed much less when there is a mechanical ventilation and is optimal when there is a spontaneous breathing. The other point that is behind the application of the non-invasive ventilation in these patients is that very often, as soon as you try to insist in delivering the non-invasive ventilation and you postpone, you delay a necessary intubation, the risk of dying may be higher again. But that there is an improvement of the gas exchange has been demonstrated not only in our studies, but in also many others, having also a reduction of the complications in these patients as soon as you may adapt the non-invasive ventilation. And the successful rate can be also in severe patients relatively high with a low percentage of death. I want just to draw your attention on the data coming from the Bellani study of the LungSafe, where the analysis of the mortality rate may be an additional point against the use of the spontaneous breathing and especially non-invasive ventilation in this context. If you see those patients who failed, and indeed a mortality rate, it is 45%. And the mortality rate of all those patients who received mechanical ventilation was indeed 25%. However, as soon as you just put together, as it should be in an intention to treat analysis, the two groups of patients who failed and who were successful, the real mortality rate of the group receiving non-invasive ventilation is 26.9, which is not so far away from the one that the patients were receiving mechanical ventilation. So one point could be, what can we do? Maybe we can try to optimize the treatment, mitigating the lung injury and improve the success rate by using a spontaneous breathing approach. And at least we should skip out and keep out of the possibility of delaying the intubation, identifying the risk factors very soon. This study has been rightly shown by Laurent, and I think that tells us a very important message, that as soon as you have an increase of the tidal volume, the possibility of having a higher failure rate is indeed very high. And this has been shown just looking specifically to these mild hypoxemia and moderate to severe, just having a clear-cut differentiation between those patients who were successful from those who indeed who failed the technique. However, looking at that, there are other issues that should be taken into account. Is time. If you look at the time when you apply this technique, the earlier it is the determination of eventual non-responder, the better it is. In this sense, some studies can help us in identifying those patients who are more severe and who are more prone to fail because they do not improve their PaO2, FiO2 within the first hours. We know that they fail in a large percentage. However, if you look at a different approach, trying to assess an index that can summarize the heart rate, acidosis, consciousness, oxygenation, and respiratory rate in order to predict the failure, you can see that the higher is the score after 1 hour, and the higher is the probability of failure, reaching the 100%. And the interesting point is that looking at the early versus late intubation, there is substantially no difference in terms of the evolution of the patient. And what emerged was that the highest severity of these parameters are the real determinant of the final unfavorable outcome. So the severity counts more than eventual delayed intubation. Again, we require then a careful clinical judgment to optimize the treatment and having an early detection. So how can we optimize? One possibility has been already mentioned, by using the high-flow oxygen therapy. I don't want to list again the different advantages that you can achieve through this technique, but were touched several times in the previous sections. The study that launched the strength of this approach, also in comparison to the non-invasive ventilation, is the Florali study from the French wing of the European academia. And in that study, the cumulative incidence of intubation was strongly in favor of the high-flow oxygen therapy, as well as in the most severe patients. And there was a difference, a significant difference in terms of mortality. Laurent said that they didn't expect these positive results. But indeed, there are many different explanations. One thing that surprised, at least me the most, was that the major difference in terms of mortality in these groups who received the non-invasive ventilation in comparison to the high flow was indeed a higher incidence of refractory shock that in general has a limited correlation with the different kind of delivering oxygen or non-invasive ventilation. On top of that, the way in which non-invasive ventilation has been given to these patients was not standardized and also very short, with some intermittent period, at least in the early phases, just depicting a situation where with between the interval of the two different trials of non-invasive ventilation, you had a sort of process of de-recruitment. Recruitment during the non-invasive ventilation, de-recruitment during the phase of the oxygen therapy, a recruit again. So something that is one of the prerequisites to induce the ventilator-induced lung injury. I want just to give a suggestion, something that can be different, at least in terms of the needing pressure that we can apply, by changing the kind of interface. We know that there are some interesting results in the past, and very recently, the effect of the kind of approach delivered through an helmet and not through a mask has been shown in US, not in our country, in Chicago, as being beneficial in terms of reducing improving the outcome for the intubation and survival in comparison to the mask. And in this case of the patient, if you look at the different pattern that this patient had, you can see that a possibility of giving a higher pressure with the helmet respect to the mask may be something interesting and to reflect on it. The real problem is that when you have a patient with RDS, we do have patients who have a low percentage of potentially recruitable lung and a higher percentage of potential recruitable lung. And in large part, this may be related to the different level of PEEP that you can apply. If you use a mask, the level of PEEP that you can apply unavoidably should be limited for a very simple reason. You increase the leaks, and so you cannot be able to recruit the lung as it should be. Maybe changing the interface, because with the helmet you can deliver higher PEEP level to the patient may in part compensate this problem. We know, however, that during the spontaneous effort, during mechanical ventilation, the maximal injury has been given through a less positive end expiratory pressure. So if I would be able to ensure a higher pressure, for sure, could be at least ensure a better recruitment. We know, however, that under the spontaneous breathing, the tidal recruitment may be better. So, which could be the conclusion? I know that my arguments are poorer than the ones that Laurent has presented, but I just try to give you a different point of view. Maybe we can do something, and we should study more into the field of the non-intubated spontaneously breathing patients, because we have the limitation of a lot of measurements. Maybe we have still a higher room. I totally agree that for those patients who are more severe, there is no alternative. It is more than logical and mandatory intubate these patients and apply all the recommendations concerning prone positioning, the muscle relaxing agents, and the protective strategies. So, the final conclusion, if you want to just apply this different vision to these patients, may be the one of identify carefully your patients, and looking at some parameters can be quite good indicator. And unfortunately, I cannot say more. Thank you very much.
Thank you, Massimo.